Hi, I'm Amy Gaynor, an occupational therapy doctoral student at Camden University, and today we'll be talking about extensor tendon repairs for zones 1 through 4 for the first 0 to 6 weeks. So first, let's go over some objectives. After this presentation, you should be familiar with anatomy and terminology of the hand, be more confident and competent in treating extensor tendon repairs for zones 1 through 4 in the most critical first 0 to 6 weeks, be able to visually identify a mallet finger deformity, swan neck deformity, and boutonniere deformity, understand the underlying mechanisms of the mallet finger and boutonniere deformities, perform a diagnostic test for a central slip injury, we'll talk about that, be able to identify the correct orthoses for each condition, and fabricate them independently if given the correct materials, be able to explain the different surgeries to a patient if they were to ask, and effectively communicate the precautions and at-home care required by the patient. When you're working with the hand, it's important to know the different anatomical parts of the hand, such as the bones, muscles, tendons, ligaments, and joints. As you can see in the image, the bones are classified into carpals, metacarpals, proximal phalanges, middle phalanges, and distal phalanges. Between the metacarpals and the proximal phalanges lies the metacarpal phalangeal joint, or the MCP joint. Between the proximal phalanx and the middle phalanx is the proximal interphalangeal joint, or the PIP joint. And between the middle phalanx and the distal phalanx lies the distal interphalangeal joint, or the DIP joint. Please do not call them pips or dips, as this is not what they are called, and it will come across pretty unprofessionally. You will notice the thumb only has one joint between its phalanges, or one interphalangeal joint, so that joint is called the IP joint. In documentation, you will see the name of each digit shortened, as you can see in the first bullet point. Some digits, like the middle and small finger, can be referred to as multiple names, but to reduce confusion, you can avoid the use of LF and use MF and SF instead to ensure clear documentation. Looking at the image of the dorsal aspect of the hand, or the back of the hand, you can see the different extensor tendon zones of the hand. Not to be confused with the dorsal compartments, these zones are used to identify and classify an extensor tendon injury so that we may know the structures that are involved and how to treat the injury. Zone 1 lines over the DIP joint and includes the terminal aspect of the extensor digitorum communis tendon. Zone 2 lies over the middle phalanx and includes the oblique retinacular ligament and the triangular ligament that holds the lateral bands together. Zone 3 lies over the PIP joint and contains the central slip and lateral bands, and Zone 4 lies over the proximal phalanx. This slide shows an image depicting brief clinical anatomy as discussed on the previous slide. It shows the anatomy of each of the extensor tendon zones in relation to external digit anatomy, or what the finger looks like on the outside. With an injury to extensor tendon zone 1, it results in an extensor leg at the DIP joint, also known as mallet finger, drop finger, or baseball finger. This is the result of a rupture or tear of the terminal extensor tendon, or an avulsion fracture of the distal phalanx. This tear results in an extensor lag, meaning the patient is unable to extend their DIP joint. If the patient had slight hyperextension of the PIP joint or laxity in their PIP joint, a mallet finger may also develop into a swan neck deformity seen on the right, with hyperextension of the PIP and flexion of the DIP due to tightening of the tendon. As I mentioned briefly on the previous slide, there are different types of mallet finger injuries. Doyle's classification system is commonly used to classify these injuries by type. Type 1 is a closed injury that may also result in a small avulsion fracture. This injury is typically treated conservatively. Type 2 is an open injury as a result of a superficial laceration and is treated surgically. Type 3 is an open injury as well, but this injury is the result of a deep laceration and requires surgical treatment. Type 4 can be broken up into 3 additional classifications, and these classifications are the result of a mallet fracture. One way that Zone 1 is surgically repaired is with a Kirschner wire or K-wire. For a Type 1 injury with an avulsion fracture seen in the top image, 2 pins are driven into the phalanges to provide more support due to the fractured distal phalanx. In the second image, you can see that a pin is driven in longitudinally to act as an internal splint and allow for healing. These type 1 surgical treatments are often completed due to a determination that the patient would be non-compliant with wearing the orthosis in conservative treatment. The wire that sticks out of the end of the finger may be trimmed down so there is less risk of infection, but may be left out for ease of removal after 6 to 8 weeks. In this case, the surgeon typically bends the tip of the pin to reduce catching. A therapist may fabricate a tip protector for a patient with an external pin. With types 2 and 3, a surgeon may decide to undergo a tenodermodesis procedure. Due to the limited subcutaneous tissue in that area, the surgeon sutures the skin and tendon in the same suture to provide more stability and utilize the limited tissue that is available. A pin or wire is placed longitudinally to act as an internal splint and provide some protection to the surgical repair. 3 to 5 days after a Zone 1 surgical repair, the patient will come into the clinic. During this time, the initial evaluation is performed, taking goniometric measurements of the PIP and MCP of the affected digit, measurements of the other digits on the affected hand, and comparison measurements of the other hand. Edema measurements will be taken during this time, and the patient's pain level will be recorded. An orthosis will be fabricated, ensuring that they immobilize the DIP joint of the affected digit. We will discuss more about orthoses later in this presentation. A home program is also initiated, allowing for active range of motion exercises to the affected digits MP and PIP joints. It is emphasized that the patient continue light, active use of the hand instead of assigning specific exercises to discourage non-use of the hand. The patient is also instructed in how to check their skin daily and allow them time to let their wound air out safely. 10 to 14 days post-op, the patient's sutures are removed and scar management is initiated with lotion if the incision site is completely healed. It is important to begin scar management as soon as possible to reduce the invasion of scar tissue and maintain proper tendon gliding and joint mobility. The patient is instructed to continue wearing the extension orthoses at all times and to maintain light use of the hand. This time, they should continue with the active range of motion exercises to the MCP and PIP on the affected hand. Skin checks are performed by the therapist every visit to ensure proper orthoses fit, and so the skin maintains its integrity during this time. After 6 weeks, the pin is removed from the injury, and mid-range DIP active flexion can be initiated with full-range active extension exercises. If the patient was previously wearing a tip protector, it may be remolded into an extension split for the patient to wear continuously. Non-surgical conservative management is successful in most mallet finger injuries. Remember, this presentation is only covering the first 0 to 6 weeks, so this is not a comprehensive conservative management protocol, and you should refer to the surgeon's notes and your facility's preferred protocol for treatment guidance. In conservative treatment, the patient's DIP joint is immobilized in an extension splint in 10 to 15 degrees of hyperextension for 6 to 8 weeks. It's important to avoid hyperextension of the DIP greater than 50 degrees because this may affect dorsal skin integrity and skin vascularization. If the patient presents a slight hyperextension of the PIP joint, include the PIP joint in the orthosis and place it in a slightly flexed position to prevent development into a swan neck deformity. If the practitioner has reason to be concerned about the patient's noncompliance with the continuous orthosis wear, the therapist may determine that casting would be a better option as it cannot be removed by the patient. If casting is determined, the DIP and PIP are both included in the cast to reduce the risk of the cast coming off. With conservative management, active and passive range of motion exercises can be initiated to the MP and PIP joints in the first 6 weeks. Normal light use of the hand is encouraged to prevent learned non-use of the hand, and patient education is emphasized during this time. It is important that the patient understands how crucial it is that they keep their DIP joint in extension. If they flex their DIP even one time, any progress with the tendon healing is immediately gone, as the tendon has not been given time to heal and the healing process is started again from the beginning. It is important that the practitioner teach the patient proper donning and doffing of the orthosis, keeping their finger in extension, and how to inspect and care for their skin. There are many types of orthoses used to treat mallet finger. Custom hyperextension immobilization orthoses are fabricated by the therapist to keep the DIP in hyperextension. Some prefabricated options, such as the stack splint, Aluminum and foam strips, and the oval 8 are also common types that you may see when working with extensor injuries. But in this presentation, I will show you how to make a figure 8 hyperextension orthosis and a volar gutter orthosis. As you can see in the first video, I'm actually making a figure 8 extension splint for the PIP joint. To make a figure 8 splint for the DIP joint, it's fabricated in the same way, wrapping the material around the more proximal phalanx of the joint you wish to extend, crossing it under the dorsal aspect of the joint, and attaching it on the volar aspect of the other side of the joint over the more distal phalanx. With this type of splint, it's important to ensure the patient's comfort and check for any sharp edges to make sure the patient's skin maintains its integrity and you don't cut off their circulation. As you can see in the second video and final image, I smoothed out any harsh edges with my fingertips and made sure to press the crossed material together so that it doesn't separate. This is important, as you'll see on the next slide. So this is an example of what a figure 8 style splint would look like on a DIP joint for a mallet finger injury. So I was saying before, it's very important that the cross material is firmly attached so that it provides the support required. You can see that I'm able to flex my finger in the splint, making it not very effective. The way I was taught to make a gutter orthosis was to start by tracing out your design on a sheet of paper. This is done to ensure proper size, keep the material clean, and to conserve splinting material as much as possible. After I traced out the size I wanted, I cut it out and traced it onto a small piece of heated material. Typically, cutting this out would be done with splinting scissors away from the patient, but I had limited table space in my home and I didn't have splinting scissors, so I did it at the same table as my patient in front of the camera. Once the material is out of the hot water bath, it's important to make sure you dry it off and check the temperature of the material to make sure you don't burn the patient's skin. This is especially important for patients with impaired sensory functions, such as a nerve laceration, as they might not be able to tell that they're getting burned. When initially forming the material, I had the patient flip over his hand to allow gravity to help me form the material over his finger and keep his DIP in extension. I also had him turn his hand over a couple more times to make sure that the orthosis was straight, and then I continued forming it around his fingers. As you can see in the second picture, it really doesn't look great at this point. The sides are too high and wouldn't allow for straps to lie flush with his fingertip if I were to add straps at this point. It's also pretty long and there are some sharp edges, and overall it just looks kind of ugly. You want to make sure that the splint that you're giving the patient is aesthetically at least smooth, so that they feel comfortable wearing it and they don't want to not wear it because it isn't aesthetically pleasing. In the video on the right, I trimmed down the sides to make it shorter around the edges, and I'm smoothing it out with my finger while it's still warm. This not only makes it more comfortable, but it also makes it look a lot better too. I'm double checking that it's keeping his finger in a slightly hyperextended position, which I could check with a goniometer if I had a finger goni around, but I found that a part of the splint needed to be flared out, so I took it to be corrected. So it looks a lot better at this point. You could see it lies about halfway up the sides of his finger, but it's still too long and there are some sharp edges proximally. After shortening it and cutting off the sharp edges, I smooth out the sides and roll the edge down to make it more comfortable when he flexes his PIP joint. So after I'm satisfied with how it looks and my patient confirms that it's comfortable, I decided to wrap it in place with Coband. I could have also used small strips of Velcro and stabilized it on either side of the joint, but Coband is just what I had available. It's really comfortable material and it's convenient because it sticks to itself too. It's important to keep in mind that it might be more difficult to put on the splint independently if using Coband, so if the patient doesn't have anyone that can help them put it back on after checking their skin, then Velcro may be a better option for them. So these are some more images of gutter orthoses. On the left, you can see a dorsal gutter with Velcro. This is made very similarly as the volar gutter we just saw, just forming the material on the other side of the finger. You could see that I stabilized it with Velcro on either side of the joint to ensure extension of the DIP as well. It was actually made on someone with a really small index finger, so it's slightly too big for my pinky, but you could still see how it fits. On the far right is an extension orthosis that was made for someone, again, with small fingers, so that's actually an extension volar gutter splint that fits the DIP and PIP. So according to Abdelghani in 2014, a satisfactory outcome for Zone 1 would include DIP residual extensor leg less than or equal to 20 degrees, a DIP flexion arc greater than or equal to 50 degrees, and of course that the patient reports minimal to no pain. If they are still experiencing pain, then there needs to be further investigation to resolve this issue. So Zone 2 lies over the middle phalanx. As you can see, it's labeled in red. And according to McKenzie in 2014 and Hatch in 2020, after the extensor tendon is repaired, the treatment is actually the same as it is for Zone 1 injuries. Zone 3 lies over the PIP joint and contains the central slip, lateral bands, and transverse retinacular ligaments. The central slip is responsible for initiating PIP extension. The lateral bands are responsible for maintaining extension once the PIP is in an extended position. The boutonniere or buttonhole deformity is the result of a central slip tear. After the central slip tears, the lateral bands sublux or move towards the volar surface, encouraging DIP hyperextension. If left untreated for 3 or more weeks, this condition becomes increasingly difficult to treat, so it's important that this condition is treated as soon as possible. If no boutonniere deformity is present, but a central slip injury is suspected, you may perform an Elson test. To perform this test, the patient puts their finger off the edge of the table. The patient's PIP should be flexed at 90 degrees and their palm should be lying flat on the table, unlike the picture where it is off of the table just slightly. If the patient begins to do this, it is important to ask them to put their hand back down flat again. Once the patient's affected hand is in position, the test is performed by holding down their middle phalanx with the fingertip and asking the patient to extend their PIP. If the patient has an injured central slip, They will test positive for the test, and they will exhibit weak extension at their PIP joint with hyperextension at the DIP. If their central slip is intact, they will exhibit strong extension at their PIP joint, and their DIP joint will be able to be passively wiggled with little tension, exhibiting a negative test. There is no standard method for a Zone 3 surgical repair. The strategies to complete the surgical repair include reattaching the central slip and reconstructing the lateral bands and moving them dorsally. The surgical repair depends on the type of injury and time passed since the injury, since, like I said, this condition is very difficult to correct after 3 weeks. Due to the difficulty, it is common for the joint to still look a bit off after surgery. According to the Diagnosis and Treatment Manual for Physicians and Therapists, 5th edition, by the Hand Rehabilitation Center of Indiana, the patient will most likely come into the clinic 3 to 5 days post-op for an initial evaluation, edema management, and for fabrication of a PIP extension orthosis for continual wear. It is typically recommended that the orthosis only include the PIP and not the DIP to keep tendons gliding and maintain skin integrity. During the first 3 to 5 days, active range of motion is initiated to all digits except for the PIP of the affected digit. Passive range of motion may also be initiated to all the unaffected fingers and to the DIP of the affected digit. 10 to 14 days after the surgery, the patient's sutures will be removed. If the wound is healed, scar mobilization may be initiated with lotion. Edema will still be monitored, and the patient should continue wearing their orthosis continuously. After 3 weeks, the practitioner should assess edema, the scar, and the range of motion of the unaffected digits to ensure maintenance of the joints. The orthosis should be evaluated to ensure PIP extension, as this might change as their level of edema changes. After 4 weeks, mid-range active range of motion may be initiated with the PIP. While this is completed, the MCP should be held at 45 degrees of flexion and allow for active extension to 0 degrees and light active flexion to 60 degrees. After 5 weeks, active range of motion exercises are progressed with an increased arc. Again, with the MCP at 45 degrees flexion, the affected PIP should actively extend to 0 degrees, and the PIP should actively flex to 75 to 90 degrees of flexion. After 6 weeks, full arc active range of motion exercises should be initiated to the PIP and DIP joints. Active PIP joint extension may also be completed with the MCP blocked in flexion, also known as reverse blocking. Just like the other extensor repair treatments, conservative management is typically preferred unless surgical intervention is necessary. In the first 0 to 6 weeks of Zone 3 conservative treatment, edema management is initiated, and active and passive range of motion exercises are initiated to all joints except for the affected PIP joint. Active and passive flexion should be initiated to the affected digit's DIP as well to limit lateral band adherence and subluxation. A custom extension orthosis should be fabricated during this time to place the PIP in full extension, leaving the DIP free. This orthosis should be worn continuously, night and day, during the healing process. These are 3 examples of orthoses that can be used to keep the PIP joint in extension. The figure 8 is the convenient orthosis. It takes little time to fabricate and is less bulky than the alternatives. The other 2 orthoses shown in the pictures are just examples of the different types of orthoses, not specifically for Zone 3. If these were used to treat boutonniere deformity, it is important that the DIP is left free to allow the DIP to maintain range of motion. Zone 4 lies over the proximal phalanx as identified in green. According to McKenzie, after the extensor tendon is repaired, conservative treatment is the same as it is for Zone 3 injuries. I will address the post-surgical protocols from the Hand Rehabilitation Center of Indiana, but remember to follow the protocol identified by your facility. First, I'll be going over the Zone 4 post-operative early active motion protocol. The first 3 to 5 days after surgery, the practitioner will perform an initial evaluation and edema management. A custom extension orthosis will be fabricated, keeping both the PIP and DIP in full extension for continual wear. A second orthosis is fabricated, positioning the PIP and DIP in 30 degrees of flexion for the short arc motion exercise program. The second orthosis will ensure the patient doesn't flex their joint past what's safe and accidentally re-injure themselves. This orthosis will allow light active extension and 30 degrees of active flexion at the PIP and DIP joints. 10 days post-op, the sutures are removed. If the incision site is healed, scar massage with lotion is initiated. Edema is still monitored and managed during this time. 2 weeks post-op, the exercise orthosis is adjusted to 45 degrees of flexion so long as the extensor lag is less than or equal to 5 degrees. At the 3-week mark, the exercise orthosis can be adjusted to 60 degrees as long as the extensor lag is still less than or equal to 5 degrees. At 4 weeks, the exercise orthosis is adjusted to 75 degrees of flexion if there is negligible extensor lag. After another 3 to 4 days, the exercise orthosis may be adjusted to 90 degrees of flexion. After 5 weeks, the extension orthosis may be removed a few times per day for 1-hour sessions to perform light ADLs if the extension lag is less than 10 degrees. 6 weeks post-op, isolated passive flexion may be initiated to the PIP and DIP joints. Another protocol the hand surgeon may want you to follow is the Zone 4 delayed protocol. 3 to 5 days post-op, the initial evaluation is performed, edema management is initiated with gauze, Coban, or finger socks, and a PIP and DIP extension splint is fabricated. 10 to 14 days after the operation, the sutures are removed and scar management with lotion may be initiated once the wound is closed. Edema is still monitored during this time, and the therapist should assess the orthosis to ensure it is keeping the PIP in extension. After 4 weeks, short to mid-arc active range of motion exercises may be initiated, as well as PIP and DIP blocking exercises. Isolated PIP joint extension may be performed while the MCP is blocked in flexion. The orthosis may be taken off during the exercises, but should be worn at all other times during the day. At 5 weeks, the patient may begin full arc active range of motion exercises. The extension orthosis may be removed a few times per day to perform light activities. After 6 weeks, the extension orthosis may be removed more times per day for 1-hour sessions. Self-passive range of motion exercises may be initiated to the digit, assuming the extensor lag is less than 10 degrees. This is begun initially with isolated passive flexion to the PIP joint with the MP in extension. The final protocol we will go over is the Zone 4 lateral band repair protocol. 3 to 5 days after surgery, the initial evaluation is performed, edema is assessed and managed, and an extension orthosis is fabricated to keep the DIP and PIP in extension at all times. After 10 to 14 days, the sutures are removed and scar management with lotion may be initiated. Edema is still assessed during this time, and the extension orthosis should still be worn continuously. After 3 weeks, mid-range active range of motion exercises may be performed with an emphasis on forceful active extension and gentle active flexion. This allows for mobilization of any adhesions while maintaining active extension. At 4 weeks post-op, the patient should begin full-range active range of motion exercises if the extensor lag of both joints is less than or equal to 10 degrees. The extension orthosis may be taken off multiple times a day for 1-hour sessions if the extensor lag is less than or equal to 10 degrees. After 5 weeks, the extension orthosis is discontinued during the day while still wearing it at night, but buddy tape may be applied to remind the patient to be cautious with their affected hand during the day. At 6 weeks, the extension orthosis is discontinued and the patient may resume normal use of the hand, although they should refrain from engaging in sports or manual labor for another 1 to 2 weeks. So just to briefly go over some of the important precautions that I've mentioned during this presentation, for all of the extensor tendon repairs, it is absolutely crucial that your patients wear their orthosis as instructed. If the patient takes off their orthosis and flexes their finger, they will snap their tendon and the healing process will have to start again from day 1. Along with this, it is your responsibility as a practitioner to make sure they know how to properly don and doff the orthosis, keeping their affected joint extended. You must convey to your patient that they will re-injure their tendon if they flex their finger during the healing process. It can be explained by telling them that their healing tendon is like a broken noodle or a rubber band, and even if it's glued together, the slightest amount of force can pull it apart. It is important that you continuously complete skin checks and monitor edema. The patient should be taught how to doff their orthosis to let their wound air out to reduce maceration. They may be supplied with a finger glove or wrapped with Coband or gauze if edema is present. Lastly, I just want to touch on some things to consider when you're treating a patient. There are different factors that may affect healing time. Although research is still divided on what factors impact healing time, it is still important that you think about these things as a practitioner, such as whether the client smokes or not, how old the client is, and any comorbidities that they may have. Keeping all of this in mind, your patient will be all healed up in no time and will hopefully be able to resume fully engaging in their daily activities. I hope you enjoyed this presentation on extensor tendon repairs for zones 1 through 4. Please reach out to me if you have any questions. Thank you.